Good evening, everybody. It gives me great pleasure to welcome you all for this very interesting webinar on antidotes and anesthesia. In November last year, Dr. Nilima Kelkar and I came across a pharma stall which had a flyer on antidotes, and the idea of this webinar came to us. Just today, I came across a post which was about 10 things an anesthesiologist should never do. Amongst it was never administer a drug without knowing its effect. So very true. I would say never use a drug if you do not know how to treat its side effects or complications. Herein come the antidotes. I hope that at the end of this webinar, we would have gained a meaningful insight into the drugs we use daily and their antidotes. 5 years back in 2020, with the pandemic striking us, all the academic activities moved to the online platform. We at THANE Anesthesia Society as well were not behind. Since then, we have conducted over 55 webinars, touching almost 10 per year. For me, it has been an enriching and enlightening journey. As the treasurer, secretary, and now the president, I have been personally involved in all of them. Today's webinar is also special for me as it is the last one in my tenure, and I'm grateful to all THANE members, the delegates, speakers, faculty, technical support, and SAMs for this platform. Today's webinar is an all-women webinar, not by intention, it just so happened. And it gives me great pleasure to welcome our two experts. Dr. Nandini Londe is the head of the Department of Anesthesia, Ruby Hall Clinic, Pune. She is affiliated with ISA, AORA, and SNAC. She is a senior teacher for DNB and CPS for the last 25 years with publications in index journals and is a peer reviewer for IJA. Her special interest is in neuroanesthesia, transplant, and regional anesthesia. Welcome, Dr. Nandini. She is also a prolific writer and writes regularly in Sakar, Maharashtra Time, Sanj Varta, and Hospital Magazine, and on Facebook. Her language is fluent and charming, and her observations about the things around us are put down in a way that appeals to all those who read it. She has written about people around her in such a beautiful way that one sees oneself in a new, better light. Our second guest today is Dr. Aparna Nerurkar. Madam is additional professor at Lokmanya Tilak Municipal Medical College and General Hospital. She was part of the team and in the Guinness Book of World Records for removing the heaviest kidney tumor in the world. She also holds a PG diploma in medical legal systems and hospital and healthcare management. She was the course coordinator for BSc PMT degree in OT technician course. She has won the Best Paper in Teachers category award and her Best Essay award at Maharashtra State ISA CME 2022. With 8 chapters and 14 publications, she indeed loves teaching and learning to teach. Our moderator for today is Dr. Sonali Saraf. She is a senior consultant at Jupiter Hospital, Thane. Her special interest is in transplant anesthesia. She is a very strong member of our team and is very much into academics. I now request Dr. Sonali to start the scientific session. Over to you, Sonali. Thank you. Unmute yourself.
Hello, everybody. Good evening to you all. So, this webinar on antidotes in anesthesia is such an interesting topic. So, whether reversal agents or other agents which are not exactly countering the effect of our drugs can be considered as antidotes was the question. So, we went back to the basics and we went through the dictionary. So what is an antidote? Actually, antidote is a remedy to counteract the effects of a poison. Or it is something that relieves, prevents, or counteracts the negative effects of any medication that is given. So negative effects, we traditionally think of an antidote, it comes snake venom, antidote to a snake venom poisoning. So we go back to basics and see what a poison is. So is snake venom the only poison? No. A poison is a substance that kills or harms you. So by this definition, it is either causing you it has a potential to harm you or is causing you such side effects that you can die. So keeping this in mind, all our anesthetic agents which we have been using have a potential for harmful side effects and also have a potential if left or used in not a proper dose, have a potential to cause death. And ours is the only branch where a little bit of everything or polypharmacy is allowed. So how is it different from a person who has taken a drug overdose in an inappropriate manner? So it's the same. And we luckily have agents now to counteract each and everything that is being used in anesthesia. Some require just patience and time, but many of them have specific antidotes available to them. So we will, with the help of the team, will go through 5 such antidotes. And I'm happy to say our young speakers are pretty dynamic UAs of our region and are ready to present this to you. Our first speaker is Dr. Manisha Singh. Manisha, can you share your slide? She is going to talk to us about a new kid on the block, that is Sugamadex. Dr. Manisha is a
Yes,
staunch member of our Yuva ISA THANE, and she is a consultant anesthesiologist at Prime Hospital, Horizon Prime Hospital at Thane. So over to you, Manisha.
thank you so much, ma'am. Very good evening to all. I'll be talking about Sugamadex, which is the so-called revolutionary reversal agent in neuromuscular pharmacology. Next. Okay. So what is Sugamadex is actually a modified gamma cyclodextrin molecule. It is a selective relaxant binding agent which reverses only aminosteroid-induced neuromuscular blockade. And FDA has approved it for antagonism of both ROC and WEC-induced neuromuscular blockade in the age about 2 years. It reversal from deep blockage is possible, which was not a feature with neostigmine. Here, Sugamadex can play a role as an antidote, as ma'am was discussing. And there also has been an isolated case report where Sugamadex was used for treatment of rocuronium-induced anaphylaxis. So it is an expensive drug, so limited use in majorities of countries. Mechanism of action is via two mechanism. In plasma, it encapsulates the circulating aminosteroid, rendering it inactive. As well as in neuromuscular junction, it promotes dissociation of the muscle relaxant from the junction. So once the muscle relaxant dissociates from the junction and comes into the plasma, it again binds it and forms a complex, inclusion complex. And it has a very high association ratio. It binds at the ratio of 1:1. So therefore, it helps in rapidly terminating the blockade. Unlike anticholinesterase drugs, Sugamadex has no effect on acetylcholinesterase enzyme. So it obviates the need of anticholinergic drugs, thus avoiding their side effects. So this is how Sugamadex binds to the ROC molecule and forms an inclusion complex. And it has a dose-dependent linear relationship, and it's excreted mainly by kidney. 90% of it is excreted within 24 hours. Half-life is around 100 to 150 minutes, and creatinine clearance of 88 mils per minute. And the complex also behaves in the similar manner. It is excreted in the kidney. So the most important is the dosing of Sugamadex. It is dependent upon the timing and the dose of neuromuscular blockade. And we need to know the depth of block. So how do we measure the depth of block? It is done by neuromuscular monitoring, TOF, train of 4, and post-tetanic count. So a routine block is represented by a TOF count of 2 or more. A moderate block is a deeper level and corresponds to TOF count of less than 2 and PTC 1 to 2. A profound block is the deepest level of neuromuscular block, and it happens within 3 to 5 minutes of giving muscle relaxant, and there is no response to the neuromuscular monitoring in these type of profound block. Adequate reversal is considered when we achieve a TOF of more than 0.9. So a dose, how do we decide the dose? So if it is a routine reversal with a routine level of block, so we need to give a dose of 2 milligram per kg, and we expect a reversal within, I'm sorry, we expect a reversal within 3 to 5 minutes. And if it is a moderate level of block, where the post-tetanic count is 1 to 2, we give at a dose of 4 milligram per kg and reversal is within 3 minutes. And but when we are using Sugammadex for reversal of profound block, which is within 3 to 5 minutes of giving the muscle relaxant, we need to give a very high dose of 16 milligram per kg, and we can expect a reversal within 1 to 1.5 minutes, 90 seconds. So this chart can guide us according to the weight and the dosing. So if it is an average 60 kg patient and we need to reverse it as a routine extubation, so we use a dose of 2 milligram per kg, which is around 120 milligram. But if we need the same Sugammadex for a profound level of reversal, so we'll need almost 960 milligram. So that will account to almost 10 ml of Sugammadex, which is 5 vials. So we need to have at least 5 vials with us for extubating or reversal of a deep block. There are rare instances or in emergency where we need to re-intubate the patient or take up the patient again for surgery. So what if we have used Sugammadex? So how much muscle relaxant can we give? So if we have given Sugammadex and within 5 minutes we need to again give a muscle relaxant or re-intubate, we'll have to use a little higher dose, 1.2 milligram per kg of rock. But if it is beyond 4 hours, then we can use the routine induction doses of VEC and rock. So for reversal of routine and moderate rocuronium and vecuronium induced blockage, similar doses of Sugammadex are required. But the catch here is the dose of Sugammadex for reversal of profound vecuronium induced blockade has not been studied. So therefore it has not been formally determined. We administer it as a rapid IV push over 10 seconds. And we have to be very careful that when we are giving the reversal, we don't have any medications in the tubing or the IV set or the cannula. It has to be clear of all medications. Neuromuscular monitoring is recommended until complete recovery is achieved, and reduced doses is not recommended as it can be associated with prolonged recovery time. So the side effects which we can expect is hypersensitivity, even anaphylaxis, even though it is rare, it is expected when we use higher doses and frequent use. There has been transient increase in activated APTT and PT, but it normalizes within 1 hour, so there is no adverse clinical consequences with it so far. Arrhythmias, that is bradycardia, can be expected, but this is less than what we experience with neostigmine. Prolongation of QTC interval may be also encountered. In renal failure patients, Sugammadex is not recommended, especially if the creatinine clearance is less than 30 mils per minute. It is incompatible with drugs like verapamil, ranitidine, and ondansetron. So like I said, when we are giving Sugammadex, we have to be very careful that there is no MSET. Like we have the habit of using MSET before extubation. So the tubings, the IV cannula should be flushed cleared of any drugs. Sugammadex may decrease the progesterone level in women taking oral contraceptives. There is block recurrence seen, especially in patients using these antibiotics, fusidic acid, and also this drug called torimifene, which is a drug used in breast cancers. It displaces the ROC and VEC from the complex. So we can expect a post-operatively sign of block recurrence. And incidences of laryngospasm is being linked with Sugammadex. Very rare. So the indication can be, we can use it in as an emergency drug in cannot ventilate, cannot intubate conditions. We can use where we are expecting a residual blockade despite standard doses of neostigmine and glycopyrrolate, especially in morbidly obese patient where there is concern of prolonged residual neuromuscular blockade. We can use it in short procedures which need neuromuscular blockade, which is like less than 20 minutes procedures. But Sugammadex, but we cannot use choline in those patients. Actually, this was the procedure where I had first used Sugammadex for reversal. It was a cardiac patient with low EF for a urology procedure, and choline could not be used in that patient. So that is the time I got the courage to use Sugammadex with rock for the first time. And we can use it for anaphylaxis where rocuronium is the suspected culprit. This plays as an antidote in rocuronium-induced anaphylaxis. Dose in elderly, it is the same as that of younger adults. There are no specific changes. Onset of action may be slower because of the slower circulation. Pediatric also now after 2021, the FDA has approved it. The literature says that we can use it about 2 years of age as a routine reversal. Obesity is the major ongoing debate here about the dosing. So the actual dose, it is recommended as per the actual body weight of the patient. There has been studied which has tried it according to the ideal body weight, but there it was associated with prolonged recovery time. So the standard here now we consider is we can use ideal body weight plus 40%. So that appears to be safe for reversal. But the recommendation is actual body weight. We can use it in conditions of myasthenia gravis. ROC and Sugammadex plays a very good combination in myasthenia gravis. So coming to a very situation where we all may not want to land up in, but would consider giving ROC followed by Sugammadex for reversal. Cannot ventilate, cannot intubate condition. Does it actually work when we need it the most? So according to the systemic review of 8 peer reviewed case reports, there were like 6 patients out of 8 which recovered spontaneous ventilation, almost 75%. 2 patients, 25% of them failed to ventilate despite giving 16 milligram per kg, and they required surgical airway. The median time for administration of Sugammadex was 6 minutes. So why it can fail? So the catch here is spontaneous ventilation involves more than just diaphragm function recovery. There are other factors, upper airway, the muscle tone, the consciousness of the patient, and overcoming the upper airway obstruction or edema, which is the most important thing. So return of spontaneous ventilation does not guarantee airway patency or oxygenation. The 4 major reasons where we can fail in CVCI condition in spite of giving Sugammadex is the timing. So timing of giving Sugammadex is the important part because according to the simulation studies, an anesthetist routine, it takes around 8 to 9 minutes to decide whether to give Sugammadex for reversal in CVCI condition. By this time, hypoxia may have already set in. So after hypoxia set in, it is not recommended to give Sugammadex. The dose availability, we should have the right dose available with us, and exact 16 milligram per kg should be given. And if the airway stays obstructed, the obstruction of the airway is the cause of cannot ventilate, cannot intubate, then even in spite of spontaneous ventilation, we may not have adequate oxygenation and ventilation. So there might also be residual effects of induction agent, which suppresses the respiratory efforts. So all these factors can cause to the failure. The ASA guidelines recommends against attempting to wake the patient if profound hypoxemia is already set in. The target should be always surgical access and maintaining oxygenation. Even the DAS pediatric algorithm 1 to 8 years includes Sugammadex only if SpO2 is greater than 80% and no bradycardia has developed. If it is anything less than that, emphasis is on oxygenation and surgical access and not reversal. So the take-home message, we should keep Sugammadex immediately available, especially during high-risk induction where we are considering ROC as a muscle relaxant choice. We should administer early, ideally before multiple failed attempts, and not wait until the SpO2 crashes. Right, the timing is the most important part here. Full recommended dose is to be given 16 milligram per kg. We have to be vigilant about the upper airway obstruction despite the diaphragmatic recovery. Consider applying PEEP and be ready for the surgical airway. Don't assume breathing equals to ventilation, and incorporate quantitative neuromuscular monitoring. So the message is Sugammadex is a tool and not a strategy. So we need to plan well, especially in these high-risk induction cases. So these are the 2 brands available in Indian market. One is from the Neon Reversi, which is available as a 2 ml vial, and the other one is Verenium, which is also as a 2 ml vial. Thank you.
Thanks, Manisha. That was a very practical talk upon when to reverse your patient, and the important take-home message was the timing of your reversal. And as you said, the starting of breathing is not equal to ventilation. So we need to plan our strategy well and always keep a plan B ready. So there are a couple of questions in the chat box, but we will take it after Aditi has finished her talk as well. So Manisha, you can stop slide sharing, and
Yes,
Aditi, you can, once she is logged off, you can
yes,
start
ma'am.
your slide sharing. So Aditi is going to speak to us upon another drug which can be life-saving in situations. With the regional anesthesia going up and becoming more popular, when we take safety, all the safety precautions while injecting the local anesthetic medications, mishaps can still happen in best of the hands. The thing is, if we know what to do in certain situations, maintain contact with the patient and keep on talking, communicating with the patient, we hope that we will catch these complications early. So Aditi is going to talk to us about the management of local anesthesia systemic toxicity with the use of intralipid. And she is a consultant anesthesiologist practicing in Thane. Over to you, Aditi.
Good evening, everyone. So today I'll be talking about intravenous lipid emulsions, cornerstone of last management. Drug details. Intralipid is the most popular brand and it is easily available. It's by Fresenius Kabi. Contents are 20% soybean oil, 1.2% egg yolk phospholipids, 2.25% of glycerin and water for injection. Formulations available are 10%, 20%, 30%. However, what we use for last is 20%. Though soybean oil is a major content in the current formulations, newer formulations are coming up with olive oil, fish oil, coconut oil, but they are still not launched in the market as yet. Approximate cost as of today is rupees 1,000 for 250 ml and it has a shelf life of 2 years. Intralipid can be used, as you all know, for parenteral nutrition. Mostly 10% is used over there. For local anesthetic systemic toxicity. Now it is also used for treatment of poisoning of non-anesthetic lipophilic drugs like tricyclic antidepressants, calcium channel blockers, beta blockers, antipsychotics, insecticides, organophosphates, and many more. But these are still under research and there are just case reports. It is also used in IVF therapy. Incidence of LAST. The first case of LAST which was treated with intralipid successfully was by Rosenblatt in 2006 and non-anesthetic agent first case report was in 2008. Interestingly, we have Indian data. There was a regional anesthesia practices survey done all across the nation in 2021. 20% of the respondents had encountered LAST and 33.4% only had intralipid available with them. Another study which was published in 2018 in the Western world says 0.03% of peripheral nerve blocks or 0.27 episodes per 1,000 blocks had LAST. Mechanism of action of intralipid. Wegener in 1998 first proposed the theory of lipid sink, wherein the lipid creates a sink in which all the free LA gets attached. So the free plasma concentration goes down and consequently you get the effect. However, later on, lipid shuttle or lipid subway effect theory has come, which says that the lipid acts as a shuttle and redistributes it from high flow organs like brain and heart to the liver for detoxification and muscle for storage, and the free plasma concentration is thus decreased. Other theories include positive inotropic effect, post-cardiac conditioning, inhibition of nitric oxide production, free radical scavenging, supplying more fatty acids, activation of ion channels, elevation of mitochondrial dysfunction, etc. As you all know, ASRA first published the guidelines in 2010 for LAST. Later on, they were modified in 2018. And there is this another modification which came up in 2020. So this is the overall chart for management of LAST. However, our focus will only be on intralipids. So obviously, call for help, get the LAST rescue kit, consider informing the cardiopulmonary bypass team. And as soon as you see any symptom, as we do not know the timeline of progress, consider administering lipid emulsions as early as possible. Now, 20% lipid emulsion, we have to administer it as bolus or infusion. Now, whether you administer the bolus first or infusion first doesn't matter. Just give it. Method of infusion, whether you give it manually, through peripheral line, central line, through a roller pump, it is not important. If your patient is over 70 kgs, give first bolus of 100 ml over 2 to 3 minutes rapidly, and then infuse 250 ml over 15 to 20 minutes. If patient remains unstable, we can repeat the bolus and double the infusion rate. If patient is under 70 kgs, a bolus of 1.5 ml per kg over 2 to 3 minutes can be given. An infusion of 0.25 ml per kg per minute. Consider using a pump, especially if the patient is under 40 kg. If patient remains unstable, again, repeat the bolus, double the infusion. Now, maximum dose that we can give is 12 ml per kg. We should not exceed that. Also, generally, about 3 bolus doses are repeated if required. Now, if your patient becomes stable, then what do? You continue the emulsion for 15 minutes or more after the patient is stable. And then we observe 2 hours if the patient has seizure, or 4 to 6 hours after cardiovascular instability. And if patient has arrested, then obviously as long as it is required. However, there are case reports which have reported biphasic toxicity, which has repeated in 12 to 24 hours. So observing the patient for 24 hours makes more sense. However, if your patient is not responding after 3 doses, then we might have to switch over to cardiopulmonary bypass for the patient. This is an image of the last rescue kit. We need to have 1 liter of 20% intralipid. NHS in the UK recommends 1.5 liters, large syringes, needles, IV tubings, and of course the ASRA checklist. If you have had an incident, later on, please report it on lipidrescue.org. Remember, intralipid should not be freezed. It should be stored below 25 degrees Celsius. We can give it even through peripheral lines. Use within 4 hours of opening. It is important to check for expiry simply because most of us haven't used it ever. So it's just there. Closer to expiry, most of the institutes use it as a parenteral nutrition and get replacements. Caution in preterm infants due to risk of fat embolism. We might have to use lower dose. As far as pregnant patients are concerned, they are at a higher risk considering the labor epidurals. But all the case reports which have been published till date, they say that the pregnant patients sailed through quite well and there were no untoward effects even on the fetus. Dibucaine or cinchocaine is now not used for spinal anesthesia for its toxic effects. Topical preparations are available for hemorrhoids, skin conditions, eardrops. Accidental ingestion of these eardrops by children have been reported. ASRA recommends on oral ingestion gastric lavage, and if there is cardiac instability, intralipid can be given. Adverse effects of intralipid: acute kidney injury, pancreatitis, obviously allergic reactions and hypersensitivity because of soybean and egg, hypertriglyceridemia, increased susceptibility to infection, pancreatitis, cardiovascular effects, fat embolism disorder, fat overload syndrome, hemolytic anemia, hepatic dysfunction, acute lung injury, ventilation perfusion mismatch, ARDS, electrolyte disturbances. ECMO machine circuit obstruction has been observed. Also, the continuous venovenous machine also shows lipid blockage. Some lab tests like glucose, creatinine, magnesium, SGOT, SGPT also get affected. Relative contraindications, obviously we need to weigh the risk-benefit ratio for the patient. The severe egg allergy, severe sepsis, pancreatitis, pulmonary disease, fat embolism disorders, lipid storage disorders, and impaired lipid metabolism. Propofol can be used according to some, but however, we are not supposed to use it simply because it is 10%. So to reach the required concentration, we will need a huge amount. And that has cardiodepressant effects, so it doesn't work. Last but not the least, I would say that intralipid is like insurance. So you're reassured that you have it, but you hope you never have to use it. So though intralipid can work as the proverbial magic silver bullet, There is no option for vigilance. Thank you.
Great, Aditi. That was a very, very nice take home. I think visually also, if we remember that slide of Phantom hitting somebody to say no to propofol, that's enough, you know. Manisha and Aditi, as well as our experts, Dr. Nandini Madam and Aparna, I request you all to switch on your audios and videos, because there are a couple of questions in addition to the case scenario that I have put up. But just wanting to know, um, uh, supposing, Manisha, this patient, there is a patient for spine surgery who's 38-year-old young fellow, but obese, 100, weighs 116 kilos. And we have obviously used propofol, fentanyl, rocuronium for induction, and maintained him throughout on rocuronium boluses, uh, with dexmedetomidine as a agent to give intraoperative analgesia and good field. So a routine anesthesia, I will say, with
Yes.
sevoflurane and this thing used as a maintenance.
Yes.
The last dose was given of rocuronium was given, say, half an hour before turning the patient supine. So after turning the patient supine, we see that we usually wait for the responses or breathing to start. He was not monitored by train of 4.
Oh.
Okay, so my essentially my question, matches with the query put by Dr. Manisha Ghosh, saying what clinical signs are acceptable in the absence of TOF machine, to go ahead and give Sugamadex, or can we
Okay.
give it at any stage?
Yes.
And what
So
dose would
in
you give?
this, if it is considered within 30 minutes, so I would consider it to be a moderate level of block. Even though we don't have a TOF monitoring, we can consider it equivalent to a moderate level of blockade of the patient. So clinical signs is the same as what we would consider for any other extubation. So we can give it at a dose of 4 milligram per kg and wait for the spontaneous ventilation and recovery. But extubation has to be based on the criteria of a normal routine extubation, whether to take out the tube. So that will also depend on the consciousness of the patient, patient's respiratory efforts. So Sugamadex will only help in getting the ventilation back. What about the consciousness? As you're saying, Dexmed was on, Propofol and inhalationals were on for the maintenance. So I would give at a dose of 4 milligram per kg, followed by routine extubation criteria for getting the tube out.
But would you wait for the respiration to begin with before reversing the patient, or you
With
can
four
just go
with
ahead?
4 milligram per kg, we can go ahead.
Okay. Um, Nandini Madam, Aparna, you would say anything different?
So if the similar scenario was around 45 minutes to 50 minutes post the last dose of rock, it would be similar to a routine extubation. So that
Right.
time the dose would be 2 milligram per kg.
Right.
Actually, means clinically, we can see that is true. Obviously, the recommendation is TOF. And in fact, TOF, they say not only just clinically, even TOF, you can just have a visual estimation that you have 4 or whatever, isn't it? They say that even quantitative is better, actually, what the Sugamadex studies are saying. But as you said, not all of us have TOF. Then you have to be very, very careful that there can be recuriorization. So the thing about being careful here is that, as Sonali pointed out, yes, just half an hour and maybe there is a OT crunch, OT time or whatever, and you're doing your reversal with Sugamadex. But it is better for the at least the patient to start breathing. And again, extubation criteria need to be met. And then you have to be very sure that you're going to wait in the post-op and see to it that uh, the patient doesn't get recuriorized. So that is one thing that they had said about Sugamadex. Don't think that you cannot get it, cannot get, especially when you're using in such situation. If you're using a quantitative method, then they say there is very less chance because you're proving that your TOF is 0.9. And one more thing is in obese, they have said that the TOF should be at least 1, because they have said now we are using total body dose. She said ideal plus 40%, which is the adjusted body weight. So they are saying that in morbidly obese, it is better that you have a ratio of 1 and not just 0.9. So all this you will do only if you have TOF
हॅलो
monitoring. If you don't have, then it
नाही
is
रात्री आहे गाडी 10 वाजता वेबिनार अटेंड करतोय
so
Ganesh,
it is better that you be ready and monitor clinically
अरे
later on.
कसं काय
Yeah.
लोकल मधून चालतं
And
That-
the higher dose is
Yeah.
better.
Yeah.
Yes.
So
Yes.
this brings me to the question of recurization. So, Manisha, can you tell us about this recurization?
So, as it can occur because inadequate has Sugamadex binds to the muscle relaxant. So there are chances that there are some amount of muscle relaxant still circulating if we giving inadequate dose. That's why they recommend adequate dosing. So the binding ratio is also 1:1. So when if the dosing used is adequate, we of course with TOF monitoring, we don't expect. But if you underdose, then we have to be very careful about recurrization in the recovery period. Then we have to be careful whether the patient is breathing adequately, the respiratory rate, the tidal volume, the attempts, and all these clinical factors should be taken care in the recovery, at
Yeah.
least for 1 hour. At least for 1 hour.
I would
Nandini
like
Madam,
to
Aparna, have you used a combination of, our neostigmine with your Sugamadex anytime? Because mechanism of action is different. The rationale being there are case reports which say that you can start your reversal so that there is competitive binding at the site of acetylcholine receptors with the help of neostigmine, and more free drug is available in the circulation, and then you can give probably a lesser dose of Sugamadex
Yes,
to
yes,
take
there
away
are
all
reports.
the medications. So
That is why it is recommended in morbidly obese for such kind. But there are very few reports, there are few literature about it where they have used normal glycopyrrolate followed by Sugamadex for the residual blockade.
I have not used.
No,
yeah.
yes.
I have also not used in this way, but
Okay.
my experience is the time from the last dose and basically the MAC level of inhalation agent. These two factors are very important because what we have observed is extubation is little turbulent and stormy with Sugamadex.
Right.
Whenever it is with neostigmine, it is little smooth and phase, in a phased manner. And many times it has happened, it is observed that patients once extubated can again have a little bit of respiratory problems. I had one patient who had a laryngeal spasm after extubating. And, they go in little slumber for a while. So you have to protect airway for some time after, taking out. So I think MAC level also is very important when you are trying to reverse with Sugamadex.
Right. A couple of questions from chat box. Has anybody used a higher dose of 16 milligram per kg? And has anybody encountered anaphylaxis because of rocuronium or either because of Sugamadex?
Okay.
No,
So,
not really.
can I ask a question?
Sorry? Yeah,
Can I
but
ask a
you have asked this question. Yeah.
Yeah. So, both the speakers, very nice presentation. And Dr. Manisha said that it should not be used below 2 years. But now, in the recent literature, there has been a lot of studies are done in neonates also. So now Sugamadex has started being used in smaller children less than 2 years and even in neonates. And my question is, supposing if you say reverse, if you give rocuronium and you're not able to intubate and now immediately you want to reverse, so you would give 16 milligram per kg. So does the chances of recurization increase in such scenario? Does it increase the chance of recurization?
So as they say, because the association constant is very high, giving this dose is 16 milligram, there's a recurrization may not be there because if you're giving the adequate dose, but then other factors may be present. I have not seen or read any studies regarding recurrentization immediately after using 16 milligram kg for a profound block. I have not found any studies
Because in
regarding.
the scenario you said that after half an hour, supposing if it
Hmm.
is used, then
Hmm.
maybe chances of recurrentization are higher, and in the post-op you should be watchful for recurrentization.
Yes. Yeah,
But
because
if
the
you
dose which
waited
we are
for
giving is less.
yes, but if you waited for 50 minutes where the patient has already started attempting, so
Hmm. Hmm.
then the chances of recurrentization are less. So here in
Yes.
the difficult intubation scenario, you've given a very high dose, say 70 to
Higher dose.
80
Yes.
milligrams,
Yes.
and now
Yes.
you're immediately reversing with 16 milligram per kg. So though
Hmm.
you've given it in 1:1 dose, but
Hmm.
then the chances of recurrentization are certainly more.
It may be present, but I'm not sure whether it will be more. And if we have a monitoring available with us, we can be sure whether it is a gold standard way of monitoring the muscle relaxant and the recovery.
Okay.
Probably we can check it with the clinical signs, whether the patient is breathing adequate tidal volume, the muscle tone and everything. But there has been no literature about it. There are very few studies also which has used rocuronium followed by sugammadex in a CVCI situation. As I said, there were hardly any case reports. So I am not sure about that.
Okay. And
It
supposing
should not be. That is
huh,
what they recommend. It should not be. If you give a higher dose, and if you see the ratio, it is almost 2 milligram per kg, 4 milligram per kg, and we are
yes,
going almost 10 times 18, 16
yes.
milligram per kg.
Yes. Okay. One more question. Supposing if you're using rocuronium for intubation, for a difficult intubation, and then you continue with atracurium infusion, or you continue
Yes,
atracurium during the
yes,
case, and
yes,
then
yes.
now you want to reverse. So in
Yes.
this kind of a scenario, would you use rock? You
No,
would use sorry,
no.
you
So
would
if
use
you've used
sugammadex?
atracurium, then it has to be regular neostigmine glycopyrrolate reversal.
Okay, okay. But you've used rock in the beginning.
Yes, for the
Okay.
induction dose.
Okay, fine. Anyways, when Sugamadex was not available, we were using Neostigmine only for
Yes.
reversing. Yes,
Yeah.
and there are few.
So that time, because Sugamadex was not available, we were using atracurium as a maintenance.
Yes,
And then because we wanted to bank on neostigmine for reversal. But now
yes,
since we have Sugamadex available, a lot of cases we continue maintenance on rock instead of switching to atracurium.
yes. And regarding the mixture like Neostigmine and Sugamadex, we were just discussing about that. So there have been few incidences where the reversal with Sugamadex say was not adequate, or reversal with Neostigmine was not adequate, or it
Hmm.
was forgotten that
Both.
rock was
Hmm.
used, and by mistake somebody has used Neostigmine for reversal,
Hmm.
but then again Sugamadex was used and then it was okay. So there
Hmm.
yeah,
There has been
people have used
incidences
like that.
there has been incidences where Sugamadex was used, but because probably of underdosing, there was not adequate reversal. So we switched to glycopyrrolate, this myopyrrolate.
Myopyrrolate.
Yeah. So
Okay.
Yes.
I'm going
And
to stop this
yes,
discussion, Saina.
okay,
Sorry.
okay, fine, fine. Yeah,
Um,
bye, bye.
because
Thank you.
Aditi, I need to
Yes.
ask you a question. If you go back to your slide of the ASRA resuscitation protocols, just one question to you. How are the resuscitation guidelines different from a patient who's undergone maybe a cardiac event with a VTAC or something like that, and similar thing happens because of cardiotoxicity of your local anesthesia, then how are these guidelines different? What are the salient features in the guidelines?
In fact, what I would like to answer this is like, this is the reason why Asara came up with this 2020 modified flowchart, because people in by default used to switch over from last to ACLS guidelines. Can you see this triangle in the middle with a caution sign? Beware, last resuscitation is different from standard ACLS. So what happens here is epinephrine is used in smaller doses. Normally in ACLS we would give 1 milligram bolus, but here we have to start with less than 1 mic per kg. Also, we do not give lignocaine. We do not give beta blockers, calcium channel blockers. Vasopressin is also contraindicated in last.
So I would urge everybody to go through the guidelines, because giving intralipid is one thing. The first thing is you have to look after your patient and resuscitate yourself. Thanks,
Absolutely.
Aditi. Can you stop sharing your screen?
Yes, ma'am.
Yeah. And I would like to invite our next speaker, Dr. Divya. Dr. Divya Rajsekharan, she is a critical care consultant at Kim's Hospital in Thane. And she is going to take us on another pretty interesting antidote, uh, that is flumazenil. So lesser known, but very useful drug to have in your armamentarium. Divya?
Good evening, everyone. Just a minute.
Meanwhile, the speakers can go through the chat box and try and answer the questions in the chat box. Aditi, there are a couple of questions for you also. So if you can do that in the meanwhile, that would be great.
So good evening, everyone. I'm Dr. Divya Rajsekharan. I'm going to talk about flumazenil, the antidote that wakes up the brain. So flumazenil, it's a imidazobenzodiazepine derivative. It is a selective benzodiazepine antagonist with high affinity for its benzodiazepine receptor. So it is a competitive antagonist, prevents or reverses in a dose-dependent manner against all the agonist effects of the benzodiazepine. So it effectively antagonizes only the benzodiazepine component of ventilatory depression that is present during the combined administration of the benzodiazepine and the opioids. So regarding the indications, there are two FDA approved indications. One is treatment for the benzodiazepine overdose and one for the reversal of post-operative sedation from benzodiazepine anesthetics. According to the American Society of Anesthesiologists Task Force guidelines, for moderate procedural sedation and analgesia, flumazenil is useful for reversal of benzodiazepine-induced sedation and respiratory depression. The combination of remimazolam and flumazenil accelerates the recovery from the general anesthesia and reduces the risk of respiratory depression compared to propofol. So there are off-label uses too. They are alcohol withdrawal syndrome, baclofen reversal, idiopathic recurring stupa, cannabis toxicity, benzodiazepine detoxification, and hepatic encephalopathy. In hepatic encephalopathy, they have shown beneficial short-term effects in people with cirrhosis, but there are no long-term benefits. So the mechanism of action, this is a picture of a GABA receptor and a chloride channel complex. So we all know the GABA is a major inhibitory neurotransmitter in the central nervous system. And it has 5 subunits, which is named after the Greek alphabet, alpha, beta, and so on. So it is basically a pentameric structure where 5 isoforms should be there. So the GABA site is between the alpha 1 and the beta receptors. So where the GABA gets attached and it triggers the chloride channel. So leading to membrane hyperpolarization, reducing the neuronal firing. So these benzodiazepine attaches between the alpha and the beta subunit, and there is Z drug, which is benzodiazepine-like hypnotics. Those are zolpidem, zaleplon, and zopiclon, which gets attached to alpha and gamma. So this flumazenil will attach to these receptors and antagonizes the effect. So pharmacokinetics, absorption after a parenteral administration, the onset of action is within 1 to 2 minutes. 80% of the responses occurs within 3 minutes. Peak effect is 6 to 10 minutes and the duration lasts for 19 to 50 minutes. And it is shown that it has an extensive distribution in the extracellular space. Regarding metabolism, it undergoes near complete metabolism with minor fractions excreted unchanged in urine, and there is no active metabolite. Elimination, it primarily depends on hepatic metabolism. Regarding the dosage, there are two dosage. One is for overdose and one is for the reversal. The overdose is we give the initial dose of 0.2 mg over 30 seconds. If desired level of consciousness is not obtained, we can repeat 0.3 mg over 30 seconds. Repeat doses can be given. Maximum for cumulative dose should be 3 mg. If recurrence is there, repeat the dose at 20-minute intervals, and it could be 3 mg per hour. For benzodiazepine reversal, the initial will be same, 0.2 mg 15 seconds. If desired level of consciousness is not obtained after 45 seconds, repeat dose of 0.2 mg only is given in this. So the maximum cumulative dose is 1 mg. If recurrence is there, in 20-minute interval, we can give the similar 3 mg per hour dose. So patients with hepatic failures, initial dose remains the same, but the subsequent doses should be modulated according, like decreasing in the dosage or in the frequency. There is no dose modification in renal impairment patients. Regarding the adverse effect, it provokes the panic attacks in patients with history of panic disorder. Convulsions may occur in patients with chronic dependency on benzodiazepine. It precipitates convulsion or altered cerebral blood flow in traumatic brain injury patients. So we should exercise caution with flumazenil in mixed drug overdosage, especially when tricyclic antidepressants are involved. It decreases the seizure threshold, therefore causing seizures. So basically, it is not effective in mixed drug overdose. So this is a popular meme where we can see in the top Voldemort representing as a benzodiazepine overdose as a powerful and a threatened force. At the bottom, we can see Harry Potter symbolizing flumazenil pushing back with his wand, showing the resistance and reversal. This is just for the information. Note, I am not being sponsored or promoting anyone. These are the two available in the market currently. One is from the Neon Laboratories and one is from the benzodiazepine. One is from the Neon Laboratories and one is from the Divine Laboratories, where we get it as Fludot and Flumacon. The price is 1,200 rupees, almost both. Thank you.
Thanks, Divya. That was a wonderful talk, because amongst all the antidotes, I think people are very reluctant to have used flumazenil, and that Harry Potter slide will remain with us, for a long time to come. We'll take the next talk quickly, because then we can go to question and a useful discussion about these two agents. I invite Dr. Asavari Wag, Assistant Professor at RGMC College and Hospital at Kalwa. And she is going to tell us about another such an interesting antidote, that is naloxone. So over to you, Asavari.
Yes, ma'am. Good evening, everyone. Myself, Dr. Asavari Wag, working as Assistant Professor in RGMC. My topic is naloxone. So as we all know, opioid overdose is one of the most common cause of mortality and morbidity worldwide. Post-operative opioid-induced respiratory depression and oversedation can lead to fatal events and increase perioperative mortality. Naloxone is a crucial intervention in this crisis and has been used for over 50 years as an opioid antidote. The aim of this discussion is to deliver requisite knowledge and discuss resources for proficient patient management during naloxone administration. How to diagnose opioid overdose? There is a classic triad which shows loss of consciousness, respiratory depression, and pinpoint pupil. Also, signs of hypoxia like cyanosis can be seen. Basically, the mechanism of action, naloxone is a pure opioid antagonist for its reversal of opioid. It acts on mu kappa delta opioid receptors and has highest affinity for mu receptors. Quickly through pharmacokinetics of naloxone, onset of action varies depending on the route of administration, as soon as 1 minute for IV. Fentanyl overdose often requires higher doses of naloxone, distributed throughout the body and thus cross the placenta. Its metabolism is through glucuronide conjugation in liver and excreted in kidney, 25 to 40% within 6 hours and 70% within 72 hours. The intranasal administration plasma half-life ranges from 1.85 to 2 hours, which exceeds the intramuscular injection, that is 1.24 hours. We have 3 naloxone formulations, 400 mics per ml of ampule vial, as well as Narcan spray of 2 mg or 4 mg. Doses for reversal of respiratory depression and sedation. Adult doses as low as 20 to 40 mics and repeated every 2 to 3 minutes. We can give continuous IV infusion at the rate of 4 to 8 mics per kg per hour. For pediatric, it is 5 to 20 mics repeated over 2 minutes and continuous infusion at the rate of 4 to 8 mics per kg per hour. Onset and duration is as shown in below. A study compares the routes of administration, which shows intranasal has longer onset of action, whereas efficacy is slightly better with intravenous route. Need for rescue dose is 2 times higher with intranasal. Coming to adverse effect of naloxone, they are hypertension, tachycardia, pulmonary edema, seizure, and acute withdrawal from opioids. So practical aspect of using naloxone, the challenges what we face while using naloxone are opioid withdrawal syndrome. In individuals who are opioid dependent, naloxone can precipitate acute opioid withdrawal. Signs are anxiety, aggression, nausea, vomiting, diarrhea, abdominal pain, and rhinorrhea. They are treated as symptomatic treatment. The prevention will be the using lowest effective dose of naloxone. Second important challenge is overdose involving multiple substances like polysubstance abuse or co-administration. Patient who has taken opioids along with other depressants like benzodiazepines or stimulants like methamphetamine. Patient may regain consciousness and breathing may improve, but they still be affected by other depressants and still poses the risk of respiratory depression. Pulmonary edema is a rare but life-threatening complication, which we will see in detail. Other challenges are rebound opioid toxicity. Major difficulty with naloxone is that it affects wears off before the opioid. Naloxone typically works for 30 to 90 minutes. Opioid who has longer half-life, like fentanyl analogs and methadone, patients still slip back to respiratory depression after naloxone has been metabolized. Continuous monitoring, repeat dose of naloxone or continuous IV infusion is the treatment for this. High potency opioids like fentanyl, where we have to use larger doses and repeated doses of naloxone. Then acute rebound pain. This is because of reversal of analgesic effect of opioid. Using non-opioid analgesic agents and reassessment of pain management is considered here. Coming to the rare but life-threatening complication, non-cardiogenic pulmonary edema, which is rare but it can be seen with pre-existing cardiopulmonary disease. The signs will be persistent hypoxia despite of resolution of respiratory depression and classic ping for the sputum. The mechanism of action is as it blocks opioid from binding receptors in CNS. In presence of painful stimuli, it allows reactivation of central pain pathway. Catecholamine surge is there and leads to sympathetic response like tachycardia and hypertension. Neurogenic release of catecholamines redirects systemic blood into pulmonary circuit. Second mechanism of action is surge in catecholamines causes pulmonary vasoconstriction, pulmonary hypertension, increased pulmonary capillary permeability, leading to pulmonary edema. Naloxone also causes laryngospasm, which can cause negative pressure pulmonary edema. Therefore, monitoring of patient after naloxone administration is important. The patient should be monitored for 6 to 12 hours as longer acting opioids can have their effects. And patient who need more than 5 mg should get admitted. In Western countries, opioid poisoning is the biggest, have more incidence than in India. So naloxone has been included in BLS and it should be used by intranasal route due to its ease of administration. Summarizing the challenges of naloxone, resedation because of naloxone wears off before opioid and repeat doses or infusion should be given. Hypertension because of sympathetic surge, the dose should be titrated and monitoring is essential. Acute rebound pain because of loss of analgesia effect of opioid and non-opioid analog should be added for this. Pulmonary edema, as we have seen the cause, oxygen, positive pressure ventilation, diuretics for its elimination, and supportive care should be done. Withdrawal symptoms, uh, low effective dose and symptomatic treatment should be given. Short duration of action, we have to do continuous infusion. So as we all know, we can have a rare and life-threatening complication. We have to use small doses of naloxone as low as 20 to 40 mics or continuous infusion at the rate of 4 to 8 mics per kg per hour. IV dose is preferred and rapid and high doses of naloxone should be avoided. These are my references. Thank you. We have Neon and Flagship has naloxone, and we also have Narcan spray available in India, which is at the cost of 300 to 500 approximately. Yeah, thank you.
Thanks, Asavari, because you often see in foreign serials, patients overdose and the paramedics arrive, give intranasal spray and the patient just wakes up.
Yes.
Well, the reality may be a little bit different. So I request Divya and
Ma'am, you are muted. Sonali, ma'am.
Ma'am, muted. Ma'am, you're muted.
Sonali, ma'am, you are muted.
yeah, sorry. Can you hear me?
Yes, ma'am.
Yeah. So I'm going to present a couple of scenarios to Divya because Divya, you come from a critical care background. So you encounter many unresponsive patients. If we thought that opioid overdose or a mixed drug overdose was only a problem of a Western world, now we are wrong. Many recreational drug overdoses are happening even in our country. And so just can you enumerate approach to a 26-year-old young patient brought unresponsive to casualty? He was found partying in a pub and his was found unresponsive. His friends got him to the casualty. So how would you approach and how do you decide what drug to give? Should we give flumazenil? Should we give Narcan? Should we give aminophylline? Or should we do something else?
First, we will go with the initial assessment and stabilization of the patient, irrespective of what the poisoning is. So we'll go by approach of A, B, C, D, E, like airway, breathing, circulation, disability, and exposure. And then we will do a history and physical examination. That will show what toxidrome the patient present with.
Can you tell us what is a toxidrome?
It's a group of symptoms which is pointing out which poison it belongs to. Like we can see in benzodiazepine, classically it will be like a CNS depression with normal or near normal vital signs could be seen. Sometimes patients are arousable and they provide the reliable history also. Classic clinical manifestations will be like slurred speech, ataxia, altered mental status. There could be a life-threatening respiratory depression if they have taken a large amount of oral ingestion is there, or if there is a co-ingestion. Most common will be ethanol, like how the case goes. And we can see which toxidrome they present with. Next, we will go with the laboratory and ECG findings. So we could send this urine drug screen and all. And in ECG, we could see any widened QRS or a QTC, which can precipitate the arrhythmias. So we could be careful with that. Then we have to go for decontamination. And next will be the antidote administration. If it is a mixed drug overdose, then flumazenil has a very minimal character in this. So if it is only benzodiazepine overdose, then it acts better. So last will be the enhanced elimination of the drug. So if a tricyclic antidepressant is being involved, so it could cause seizures when we are giving flumazenil. So we have to give only in benzodiazepine overdose or Z drugs, that hypnotic like benzodiazepine drugs. So in this two, flumazenil is effective.
Yeah. Asavri, would you add anything to it? Approach to an unresponsive patient. So if the toxidrome is pointing out towards opioid overdose, like
Yes, ma'am.
is
We can give
respiratory.
naloxone by intranasal route and probably because of ease of administration. But I would suggest, as we have seen the deadly adverse effect as pulmonary edema, we should give it slowly titrated or even infusion can be given. It is, yeah, we can reverse the respiratory
Yeah, so
depression.
it is never a very clear picture in when they come up with overdose, because whether it is aspiration related
Yes,
ARDS or is it pulmonary edema may be also difficult to diagnose. So in TV serials they show give naloxone and the patient wakes up,
yes,
may not be entirely true if there is a mixed drug overdose. I believe Asavri, you have a couple of case reports
yes,
highlighting
ma'am.
this pulmonary edema under anesthesia or after the anesthesia has been reversed. So can
Yes,
you just present to us those cases
yes,
or
ma'am.
just read out?
Yeah, actually, there have been reports of pulmonary edema where CVT surgeries, like long duration surgeries, more than 3 hours, where we give fentanyl more than like 1 milligram or 2 milligram. So there, they have been reported that when we reverse the patient with naloxone, and if we give more like 2 mg naloxone or more than 0.4 mg naloxone, there they have reported pulmonary edema. So there was a case of 65-year-old 80 kg man with coronary artery disease given fentanyl of 2 mg in 3 hours, more than 3 hours surgery for artery bypass. And patient was intubated and mechanically ventilated after surgery, then transferred to ICU. But surgeon elect for early extubation. And then, as patient is deeply sedated and not responding to painful stimuli, they have given naloxone of 2 mg and along with fumazenil, obviously. But patient had acute hypoxemic events and pink frothy sputum and X-ray shows infiltrates. So here the take-home message will be slow and low doses of naloxone to be administered. Many such cases have been reported just because the dose is not given correctly or slowly. Rapid and high doses of naloxone has been given, so we can avoid those complications.
Okay. A similar case you had shown about a shoulder arthroscopy patient who was not
Yes.
waking up at the end.
Yes.
So, Divya, any role of aminophylline or respiratory stimulants like doxapram, Asavri, you can also take this, um, for, starting the breathing if the patient is not breathing at the end of the surgery, because these are central stimulants of your respiration. So, any role in casualty presently or any? Yeah.
Ma'am, in residency, we have used it, but nowadays aminophylline is a very narrow therapeutic index. So it can cause arrhythmias and seizures. So we don't use routinely actually because of its narrow therapeutic index.
Right.
So we,
Aparna or Nandini madam, if a patient, do you agree with their management? If the patient comes to us who's unresponsive and a polypharmacy like multiple drug overdose has happened or like under anesthesia multiple drugs have been used, so the approach, how would you approach such a patient? Would you use aminophylline or doxapram in these cases because they had a role previously but
Um, Yeah, whenever we are doing polypharmacy in routine cases, and if the patient is not waking up after the surgery, then there are other parameters to be looked for. Then we normally send for ABG. We try to correct the acidosis. We try to see whatever drugs we have used has eliminated or not. And I think then in the end, may we can think of giving them antidotes like naloxone or doxapram or aminophylline. So actually, many times we try to ventilate the patient for a little longer and try to stabilize all things. So no, I as such as not used naloxone or doxapram up till now for routine cases, but I'm sure it must have been used in the critical care areas definitely.
so Manisha, Dr. Manisha Ghosh had a had a question that aminophylline has been used as an antidote, but presently aminophylline, as Divya said, has a very short therapeutic margin. So we have to be careful, especially if cardiac instability comes into play. Aparna, you want to add something to the
No. For me, I have used naloxone, but I have used when actually the patient we have reversed, extubated, but slightly drowsy, and then there was a calculation of fentanyl dose that was given, and she was an old lady. And then we have used naloxone because again there was some kind of little respiratory depression. We were not happy with the rate, and naloxone helped, but we had used only 0.2 at that time. And then we had a case of fentanyl patch, which was probably put over an abraded area. And then suddenly within an hour, the patient was found unresponsive. Means found in the sense, we saw that he was unresponsive. We were monitoring him in our critical care area. So immediately the fentanyl patch was removed, and then I have used naloxone. So that is where I have used naloxone. Otherwise, routinely at the end, as Madam said, that we will be sending everything, and then probably, and midazolam actually I have almost stopped using unless the patient is extremely anxious. So flumazenil I have not used at all.
Yeah. So to be kept in mind, remimazolam, which is upcoming new drug, which will be in market in some time to come. Your flumazenil also works against it. So happy to learn about flumazenil. Divya, thank you. Asavari, thank you so much. Shall we move on to the next topic? Yeah. So I invite Dr. Foram Gandhi to present to us on a very hot topic, that is dantrolene. Dr. Foram Gandhi is working as a consultant anesthesiologist at Jupiter Hospital, and she is going to talk to us about MH and the use of dantrolene in prevention of or treatment of MH. Over to you, Foram.
Good evening, all, and thank you for the opportunity. And yes, as Madam rightly pointed out, I'm talking on dantrolene today, like the hot topic usually these days after the incident. And initially, what we thought that MH is probably doesn't happen in India, and we are probably safe from it. But no, now that it has happened, we need to be very much aware of this. I remember reading about it only as a theory topic for my exams, but now we see it as a reality. So let's talk about dantrolene. Sorry, this is stuck. Yeah. So as we all know, that's the only known treatment for antidote for malignant hyperthermia. And because of its relative, high cost and inavailability, we usually don't have it. And the high dose which is required, but now we've started stocking it. So this is the Agilis, which is the combination available now currently in India. Before I talk about dantrolene, just a short pathophysiology of the malignant hyperthermia. As we all know, in MH susceptible individuals, exposure to trigger agents like succinylcholine and inhaled anesthetic agents, it causes disruption of the ryanodine receptor, which is present on the sarcoplasmic reticulum, which acts as a calcium channel ion. And the inability of it to repolarize leads to unregulated and excessive release of calcium from the sarcoplasmic reticulum. This elevated calcium is basically responsible for the cascade which then follows, leading to sustained muscle contraction and rigidity. It stimulates the aerobic and anaerobic metabolism, leading to excessive demand of oxygen and adenosine triphosphate consumption, leads to metabolic acidosis and sustained increase or generation of heat, which together then establishes the hypermetabolic state and the hyperthermia ensues. Mechanism of action, it is not very clearly known, but it is suggested that it binds to the ryanodine receptor and it inhibits the release of calcium into the sarcoplasmic reticulum, thus causing excitation, contraction, coupling dissociation. And by inhibiting further calcium release, it allows the muscles to relax and causes arrest of the metabolic cascade. But this we should understand is important even only when given in the earlier stages, and time is of crucial importance. The composition and the pharmaceutical form available. As I said, in 2024, the European Union had approved of this particular formulation of dantrolene sodium hemiheptahydrate, wherein each vial, initial vials which were available, that is of dantrium, were only a 20 milligram vial, which had to be diluted in 60 ml of water, causing a tedious mixing time and a long time. The ones which are available now, this vial is a 120 mg dantrolene hemiheptahydrate lyophilized yellow-orange powder, which needs to be diluted with 20 ml of sterile water, and the excipient used in this is hydroxypropyl beta-dex, which is 3.5 grams, versus the one which is used in the initial formulation available of dantrium was mannitol, wherein each vial of 20 milligram had a 3 gram mannitol, versus this is 120 milligram with 3.5 gram of hydroxypropyl beta-dex and sodium. As I said, the vial is available in the strength of 120 milligram, which should be constituted by adding 20 ml of sterile water. No other solution should be used for reconstitution except sterile water, and it should be shaken approximately for a minute till a clear free particulate solution is achieved. But to be able to administer it, it probably takes, the complete dissolution process takes 3 to 5 minutes. The reconstituted solution. Sorry.
Okay.
The reconstituted solution is highly alkaline with a pH of approximately 9.5 and is to be given through large veins or central veins because of this high alkalinity of the solution. It should not be mixed with other solutions. As I said, it's incompatible with other solutions with dextrose or ringolactate, or should be given via the same access with a running fluid. Because of its high alkalinity, also any spill on the skin of the provider or of the patient should be avoided. And if it does happen, it should be washed with sufficient water immediately. The dosing, the initial treatment is a dose of 2.5 mg per kg bolus dose to be given over 3 minutes, to be repeated every 5 minutes till resolution of symptoms. Maximum dose is 10 milligram per kg. However, higher doses may be used in especially severe and fulminant cases, or sometimes when it is taken time for you to procure and administer dantrolene. However, you should rethink about the diagnosis when there is no resolution of symptoms even after 10 milligram per kg. But however, saying this, people have used even higher doses, as I said, because in sometimes the cascade is already set in too much and you may require higher doses for the same. After initial bolus, maintenance dose is required of 1 milligram per kg every 4 to 6 hours for at least 24 hours or occasionally even 48 hours while monitoring the patient for signs of relapse. The incidence of relapse is around 15 to 20%, once again, more in severe cases. If any relapse does occur, that means worsening of symptoms, or you start seeing rigidity and elevation of temperature with EtCO2, which had come down, then you should treat it as a malignant hyperthermia episode, fresh episode with initial, go back to the same dosing again, like 2.5 milligram per bolus, and then keep on repeating it every 5 to 10 minutes till there is resolution of symptoms. While treating malignant hyperthermia, dantrolene though is the cornerstone, but also there is a complete multimodal treatment which needs to be taken, wherein you need to address multiple issues, most important being of hyperthermia. So along with that, when you're doing, and because there are tachyarrhythmias, and while you're using your ACLS guidelines, concomitant use with calcium channel blockers needs to be avoided because there is a high risk of cardiac dysfunction, exaggerated myocardial depressant function because of dantrolene and the calcium channel blockers, sometimes leading to arrest too. Dantrolene can be stopped, or the interval between the doses, as I said, even after the resolution, it needs to be continued for 24 to 48 hours. Initially, you have to repeat 1 mg per kg dose for every 4 to 6 hours. However, that can be reduced and the interval can be increased to 8 to 12 hours if all The point to be remembered, all, not one of these or few of these, all these criteria have to be met. Metabolic stability for 24 hours. The core temperature is less than 38 degrees Celsius. Creatine kinase is a decreasing trend. There is no evidence of myoglobinuria and the muscles are no longer rigid. A brief note on the pharmacokinetics and dynamics. It is used as intravenous injection. The half-life after 60 and 120 milligram dose is around 8 to 11 hours. In children, it is 10 hours. The whole blood maximum concentration, Cmax, achieved after a bolus dose is around 4.2 micrograms per ml. And this Cmax is good enough to block up to 75% of skeletal muscle contractions. It reversibly binds to plasma albumin. Almost 94% is bound to albumin. And it undergoes metabolism through the microsomal enzymes in the liver via 5-hydroxylation of the hydantoid ring and reduction of the nitro group to amine with subsequent acetylation. The hydantoid derivative, I mean the hydroxylated derivative, is as effective as the parent dantrolene, whereas the acetylated derivative is not pharmacologically active. Elimination is elimination half-life is around 9 to 11 hours, and excretion is mainly renal and biliary. As I said, the excipient used, the hydroxypropyl beta-dex, which is an ingredient of the Agilis formulation, it is cleared by renal filtration unchanged. And in individuals with normal renal function, the half-life is 1 to 2 hours. But what we need to understand that when we are using it in a case of MH, because of myoglobinuria and continuous rhabdomyolysis, the creat function is elevated. I mean, the renal function is deteriorated, and there may be delayed excretion of your hydroxypropyl beta-dex, the excipient. The shelf life of this particular dantrolene is 3 years. Agilis formulation is 3 years of an unopened vial. Once opened and reconstituted, it is should be used within 24 hours. It should be protected from light and kept at 25 degrees Celsius. Should not be refrigerated. Indications, it's a life-saving and it's the only known antidote for malignant hyperthermia. Other indications in which dantrolene has been used is neuroleptic malignant syndrome. As an oral formulation for a chronic long-term therapy, it is used in spastic muscle conditions, in cerebral palsy and other spastic muscle conditions. Side effects, once again, it is a life-saving antidote, so we have to use it when we have to use it. The other side effects which are mentioned are usually on an oral or long-term usage, but even after MH, because of large doses of dantrolene which is used, there is muscle weakness which is seen in 22% of the patients. Phlebitis, as I said, it's a highly alkaline solution, so that there is a very high risk of phlebitis. 10% respiratory failure and a GI discomfort, small percentage. Hydroxypropyl beta-dex, the excipient used, is said to be ototoxic at higher doses. Higher doses means when the dantrolene is used it at 10 mg per kg or higher doses. Also, it is transient and is seen more when it is used with other ototoxic agents or with a impaired renal function patients. Dantrolene is hepatotoxic when used over long-term use, so it needs to be monitored. Whenever you're using dantrolene, you need to monitor with continuous LFTs to see its progression, and you may need to stop it. But this all is for oral use of dantrolene. However, while we are using it as a life-saving antidote and life-saving measure. And plus, there are multiple things, metabolic cascade which is happening. So all of them, they play a role. Thank you.
Thanks, Forum. That was a very precise and a very, very practical talk, because I remember reading reconstitution of dantrolene also takes 15 to 20 minutes. So can you elaborate on what other supportive therapy should be ongoing till you get dantrolene in hand?
Yeah, so dantrolene, so there have been actually certain case reports from India also wherein dantrolene is not available and you have to start with supportive therapy. The most important being managing the temperature. So once the temperature starts rising, you have to first suspect it, inform the surgeon, finish the surgery fast. At the same time, bring in cold IV fluids, maybe, if depending on what the case is, you have to insert a large vein cannulas, probably a central venous line to the arterial cannulation for monitoring, and temperature probe if it was not already inserted. So all these measures you have to start with cold IV fluids. You may have to give cold bladder washes, put cold saline bags near the axilla, and to get the temperature down. Also, if you have a convection, that forced air warmer, instead of warming it, you can use the cooling function of it. So that is talking about temperature. You need to change your ventilatory parameters to get the ETCO down. But of course, that is difficult because of the pathophysiology, as I said. Then starting deal with the metabolic acidosis which happens. So, correction with sodium bicarbonate, and running IV fluids, use of antiarrhythmic agents, and treatment of hyperkalemia. So you have to start a glucose insulin drip, and maybe a salbutamol nebulization too. Use of diuretics, you have to, because of myoglobinuria and that rhabdomyolysis, you also have to keep the urine output. Urine output has to be maintained at 1 ml per kg. And as I said, and also watch for DIC and treatment for that. All of this should happen simultaneously. The most important, sorry, which I forgot to say, is call for help, because you need many people. Yeah. It's not possible for a single provider to be doing all this. Absolutely. So you need all the possible help. And also
change your machine. Stop inhalations.
Removal of trigger agent.
Yeah. So we have heard about a lot of incidences that are happening even in the Indian population now, and that's why the drive to procure dantrolene has been happening. Nandini madam, can you share your experience about what happened recently in Pune, and as a warning to us who have yet to procure the drug, and maybe encourage us to buy it pretty early?
Yeah, actually, the incidence of MHE was very low. I mean, we have just heard and read in the books, but last 1.5 years, there are three cases which happened in and around Pune. Two I specifically remember because one was some 14-year-old boy came for a close election, and he was given schooling, and immediately the typical symptoms started with tachycardia, hypertension, increased temperature, and before it was picked up, they realized it could be MH, and then the supportive therapy was started. But then, since the dantrolene or antidote was not available, we could not save that boy. So that was pretty unfortunate. The second case, which happened recently, some 6 months ago, was a young man, 42-year-old, coming for a cosmetic surgery, rhinoplasty, and he had a previous history and exposure to anesthesia because of other surgeries. Typical, we had this thing, it was induced with actually normal this thing, but the sevoflurane was used. And I think for induction, the anesthetist had used succinylcholine. And during the procedure, it was okay. But after some time, after 1.5 hours after starting the surgery, the symptoms started, and they were typical and sudden in the onset. And before they realized it, they thought it might be MH. And then all the supportive therapy started, and the messages started coming everywhere. Want dantrolene if possible, you can procure from anywhere. Even on the hospital association group, even our CEO has called me if we have available in the hospital. So I was quite surprised. It went viral everywhere. But the same thing, patient we could not save in the end. And it was very, very unfortunate. And then suddenly everyone was, kind of woken up from the slumber that yes, it is a possibility and it is happening around us and we need to procure somehow. So the discussions and so many things started at the same time on different forums. And I'm very happy to say that with crowdfunding, the ISA Pune has procured that drug 2 months ago. And it was a great achievement because of realizing the impact of this on the practice and medical legal aspects. I think everyone was very open to help in this process, and they contributed very generously, and we could procure the drug actually. And second
So,
thing is from, yeah.
no, madam, how many vials have you procured? And it is 120 milligram per vial?
No, from our hospital, actually, I also requested the management and showed them that it is a very urgent and we need to have this drug in our position. We cannot be dependent on other people, and the logistically where the drug is going to be kept from there to transport it, and so many logistic difficulties can be there. And I explained them that it is on the rise, and we being a corporate hospital and tertiary hospital, we need to have our own. And somehow, fortunately, they agreed to it. And then we actually approached the Food and the Drug Commissioner, and he readily gave his this thing for creating a code for it, because you need a license to import the drug which is not produced in India. So we got that permission. Then they said that the company said they need a patient's detail with the names and the Aadhaar card or whatever important document. So actually, we got that from one of our employee who was admitted, who was supposed to be getting admitted for some small surgery, and he readily gave all the documents to us, and we actually got it from a company called as Paladin, and it is a dantrium sodium, which is a actually six vials, 20 milligram per vial. So one pack is 120 milligram. So we got two packs of this. So total is 240 milligram in our possession. So I'm very grateful to the management, and it is actually in our possession. At the same time, I suggested that we might have a collaboration with other hospitals who are nearby in the vicinity whenever they are required. So we created a SOP also for the use, like if there is going to be requirement and how to approach, how to give details, how to have a transport, how to financial details, how we are going to give all the expenses, and everything is in place. And I think it is going to be very helpful for the people, especially on and around, and especially the freelancers who may not have access to this drug so easily. So this is how we
How
got it.
much time did the whole process take about getting the license and approval done? So a realistic this thing to after
Yeah,
you start, you decide that you have funds and you would want to go for it. How
yeah,
much time did it realistically take?
yeah, it took almost 3 to 3.5 months to get the drug in possession.
Okay.
So for us, for our hospital, the funding was not a problem. They funded on their own completely. But ISA, Pune ISA Society, the crowdfunding took little time, but at the same time, they started the procedure. So I think the time was around the same 3 months to get the drug in the possession.
Okay. Thank you so much, madam. I just wanted to ask Forum, are all MH cases fatal?
No. So it depends. So even all MH cases, what we really think that, they may go into the final spectrum, what we said that, all of them would be, some are only very minor. So some may not have the full-fledged cascade, or some they may just have the masseter spasm, which is usually the first sign after succinylcholine administration. And that may prompt the anesthetist if, seen to stop further and start treating. Also, some cases have been treated without dantrolene and just with the supportive treatment, and not all cases are fatal. It ranges from just hyperthermia and few symptoms to this complete cascade which we just discussed. Not all cases are fatal, but some are.
Yeah. What are the recent advances that are going on? Like we had 20 milligram per vial of dantrolene. Now it's 120 milligram per vial. What should be done, to what is being done rather in the procurement, or rather the formulation of dantrolene?
So yeah, so in the US, so this is what I said, this Agilis formulation what we have, that is in the European Union, that is mostly used in Europe, and which also is procured in India. The formulation which is used in the US, that's a Rhinodex, that is 250 milligram per vial, so that is even faster. Even the dissolution rate is much faster, but of course it is not available anywhere else currently apart from the US. And there is research going on about the newer formulations wherein they combine the nano suspension technology with a lyophilized formulation, resulting in faster reconstitution, which improves the time to treatment. Or also, especially because all these wild dissolution, reconstitution, administration require multiple caretakers, providers. So if you have a concentrated one, a more potent one, wherein you don't need multiple vials, probably one single provider can do that. Also, research is going on wherein azumolene is the compound where they're seeing wherein the bromine residue is, it has a bromine residue which instead of the nitro group, and it is 30 times more potent and water soluble. That is the development. I mean, they are looking into research is going on for that.
So the 240 ml vial, milligram vial, you say is in use in the US, right?
Rhinodex, yes.
Rhinodex. Okay. So we have time to take questions from the chat blocks. Aparna, you have encountered any cases of MH?
No, absolutely not. Here I was just listening to everybody. I have not, luckily.
Yeah. Muscle biopsy, whether should be is diagnostic and whether it has a role, how practical? Where can we send these patients for biopsy? The classic caffeine test or anything? Any idea?
I actually don't know where in
no.
Maybe I don't know.
Nandini madam, any center which does muscle biopsy for these patients? Or once established, it is a clinical diagnosis on table. Forum, if you are presented with such a case like EtCO2 going high and temperature rising, what other things come to your mind? What are the differentials?
So the differentials in these, as I said, which you have to consider is the sequence of clinical events. The other thing, sometimes sepsis can also, present to you like that, wherein there is, hyperthermia. It may not have the whole complete spectrum. The other thing, which can be neurolep malignant syndrome and sometimes pheochromocytoma. So these are the differentials which we can keep in mind.
How would you rule them out one by one to reach the diagnosis is the question.
Okay.
Nandini madam, you wanted to say something about these differentials or?
Yeah, thyrotoxicosis can also present there.
Thyroid storm.
Yeah. So yes, it is a difficult thing to handle when a complication happens. The supportive therapy should not stop. How late can we give dantrolene? For example, if a center is at a time of 2 hours away from our center, and we have continued with the resuscitative efforts, as you said, all the supportive therapy is in place, it's ongoing resuscitation. So till what stage can you give dantrolene, or beyond this you cannot give dantrolene? Like
I think you
2
can
hours
give
have
dantrolene.
passed, or if it is taking a long time for us to reach, then what should be done?
So as you said, if the patient has sustained for 2 hours till your dantrolene is available, then it is very much, I think, you should go ahead and give dantrolene. Though the guidelines say it should be given within 5 to 10 minutes as early as possible, but in our scenario, that is not possible. But if you've been, because if it's severe, then, the patient may suffer cardiac arrest, may not sustain all this. But if the patient has sustained for, a couple of hours, then there's no harm in giving dantrolene, because once again, that is the only antidote which is known, and that will halt the pathophysiological process of calcium release, which will bring a halt, if not reverse the whole thing. Otherwise, the cascade keeps on continuing and you're just doing the supportive treatment. So I think at any stage, if you get hold of dantrolene, you should be giving,
So
dantrolene.
even if it is later in the stage when even the patient has sustained cardiac arrest and you are continuing with all the measures, you are able to see that the urine output has started dropping. Still, if dantrolene comes, you would still want to give it, right? Aparna, you have...
No,
Like,
I really
at
don't
any
know.
stage, when would you say no, and when would you really say it's too late to give dantrolene? Yeah, there is a question in the chat box also. What about oral dantrolene? Is it available?
Oral dantrolene is not easily available here.
No, oral dantrolene is available because it is being used for all the cerebral palsy kids and all. But it is not recommended to be given in a case of malignant hyperthermia. Not orally. Not orally. We had one more webinar last time where it was specifically, Nandini Dave madam was there and she insisted on taking this take-home message that oral dantrolene cannot be used in malignant hyperthermia. It has to be the IV formula.
I think oral dantrolene is used for those spastic muscle conditions and cerebral palsy. And they're saying in Alzheimer's also nowadays they are finding out the effectiveness because these are those receptors which are causing memory loss. If it is blocked by dantrolene, then Alzheimer's can be, the progression can be halted. That is what the research is going on.
Anything through the Riles tube about oral dantrolene, it will not work in time. It may not work in time because it takes some time for it to dissolve, and absorption isn't guaranteed in your critical care scenario, as Forum has mentioned. So IV dantrolene is the thing to, give whenever it is available. And we hope that our efforts through THANE ISA or through corporate hospitals come to fruit, and we can see this happening in future. Manisha, you wanted to add something?
Yeah, about this procuring of dantrolene, the MMRDA, matlab the ISA associations within Mumbai metropolitan area are all in talks about procuring it for our city, so that we at least have 6 vials which are available in some part of the city, and each association will have one. So if unfortunately such an incident does occur, then every city will have at least a suburb and close by areas will have one ampule to start with, and then we, transport the other as early as possible. Like Forum said, if the patient has sustained for a longer period of time, then I think that will give us some adequate time. The major issue is this only about where to store and how to reimburse, and in all probability it will be a wasteful expense, but then we have to consider it as a investment for saving one life if possible. Even if it goes waste, it's okay, but if we can do that, it is well and good. So all talks are in place going on, and many branches like Manjiri madam from Nasik just said that they could procure it in 1 month. So maybe she can also have something to say. Dr. Manjiri, how you could manage it in 1 month, and what was the process you went to? If you could tell us. I don't know whether she's still there in the meeting. But yes, talks are underway, and hopefully we should be able to do something. At the same time, we have told our SAM's president and secretary and the executive committee that it should not be the onus of the city branches and the individuals to procure it. It should also be the responsibility of the societies to, get it for us at a cheaper rate, make it easily available. So we are also trying to have meetings with the health minister or the person in the municipal corporation who are associated with the health department. And hopefully, sooner or later, we should be able to streamline this process of getting the drug easily and at a cheaper rate.
Yeah.
The current cost of this Agilis vial, which is 120 milligram, is 1.15 lakh. So it was recently procured by Vadodara ISA in collaboration with the Rajkot ISA and a branch from Maharashtra. I think Nashik. Nasik, yeah. So then each of them, they procured the box, and each society took up 2 vials. So I think with even 120 milligram, one vial of 120 milligram, it should be, you're at least able to provide 2 to 2.5 mg per kg for an adult, 50 kg adult patient. So at least, the first dose you've given. So if that, even that can be, good.
Yeah.
So
Rather
that
than
is
not having anything.
the whole idea. That is the whole idea.
Okay, can
So
I
then,
ask a question to Nandini madam?
Yeah,
Hello?
yeah.
Yeah. So I wanted to know that the casualties which you had in Pune, so was any confirmatory diagnosis made that was it proven that it was MH only, or just with the symptoms you just thought that it is MS?
No, I think it was whatever symptoms was presented and how the patient progressed. I think from that, I
Okay.
think the biopsy was done later on. I don't think so.
Okay. Okay. And I wanted to ask regarding flumazenil, whether it can be used for post-operative cognitive dysfunction. Supposing you've given diazepam, say midazolam during your anesthetic, and if the patient is very disoriented, delirious in the post-op, can you use it for post-operative delirium? Because I think it is mentioned that it can be used in encephalopathy also, hepatic encep. So,
So what they say is that flumazenil itself, because it acts on both benzodiazepine A and B receptors, the B
yes.
receptors themselves can lead to anxiety, confusion, and convulsions. So I am a little doubtful whether you can use it for all post-operative delirium. In the specific case that you said, diazepam or midazolam, if we suspect, if I think if it is, if you suspect it's an overdose, they would probably be sedated rather than confused. So I am a little unsure. But if we are sure that whatever the symptoms are, they are due to benzodiazepines, then only flumazenil will be of use. Other cases of delirium, in fact, you may cause more anxiety, trigger confusion, trigger convulsion. So I don't know whether flumazenil can be used that way.
Okay, thank you. And for
Excuse me,
remifentanil, yeah,
Parna.
yes, yes,
I just got myself unmuted. Shall I talk? Dr.
yes,
Manjeevi
please,
from Nasik. I was not figuring
please
out
go
how
ahead,
to talk.
ma'am.
I
Yeah,
think
yeah, yeah.
still my video is not on. I
No
don't know.
problem. You can talk,
Okay.
ma'am.
Okay. We got it at 94,000 only. It is not 1.5 lakhs. We got it exactly at 5 lakh 66,000, including packaging charges, including delivery to our hometown and GST, everything. So it is not that costly.
So
And
this
for a
is
branch,
Agilus, right, madam?
Agilus, yes, 120 milligram.
120 milligram and a
Yes,
box
yes.
of 6.
No, we got only one because
One, yeah.
yeah, we were 5 cities, na Jaipur,
Yeah.
Vadodara, Rajkot, Nasik, and Aurangabad.
Okay.
So Vadodara kept 2. We actually wanted to have another. We want to have another dose. So we are looking for someone who can do another partnership with us.
Actually, we got it whole 240 milligram. I mean, two
Yeah.
of 6 vials for
At
1.96, excluding shipping charges. So we can
okay.
it can
But
be 210 or 215 at the most.
but shipping charges are like 150 US dollars.
No,
Like
well,
another 15,000, 20,000 maybe.
whatever. But hospital got it at around 2, not more than that. Whatever. I
Yeah,
think.
because now I also inquired with our agent
Hmm.
because he has import-export license and they procure a lot of cancer medicines.
Right.
So they got it from their own package.
Exactly.
So that is why you got less of shipping
They clubbed
charges.
with other delivery and got it with that. So I think that is
Yeah.
why those charges were not included in that.
Mm-hmm.
We got it for around 2, not more than that.
Great.
Yeah.
What a
I want
stimulating discussion this has been.
Sonali, I wanted to
Yeah,
ask
Parna, yes.
regarding naloxone.
Yeah.
So, see, Remi is a very short-acting opioid. But supposing if you have severe, say, chest rigidity or apnea due to high dose of Remil, then can you use naloxone? Are there any articles on that?
Asavri, you want to answer this?
Yeah, yes, ma'am. Remifentanil, we can use naloxone actually. Just because it is fentanyl analog, you need more larger doses of naloxone.
Okay, so there
Like
have
100
been
mics.
reports.
Yes, yes, like 100 mics or.
Usually after Remi, the chest wall rigidity would go if you start with the induction agent.
Yeah,
It makes
exactly.
you, yeah. So
Yes,
generally not required. You stop the infusion and the patient would be awake
yes,
by the
right.
time. So
Yes.
yeah, with the things like apneic ventilation and giving
Hmm.
extra oxygen during induction would help prevent hypoxia if there is a chest wall rigidity at that time.
Right.
So, yeah, thank you all so
Thank
much
you.
for being a part of this wonderful CME. If you have one take-home message regarding your antidote to give, what would you say, Sugamadex, Manisha, you would like to say one take-home message about use of Sugamadex?
So use of Sugama Dex, if we are planning to use it in a CVCI kind of situation, then it is the timing and the dosing, which is very important. Second, if we are using it for a routine reversal and we don't have a TOF and we are unsure about the TOF count and clinical signs, always use the higher dose to be sure about to prevent recurrentization or blockade again. So always use a higher dose. So these two
Aditi,
things I would recommend.
Aditi, you want to say something about intralipid? One take-home message? Divya? Unmute, unmute.
Flumazenil, use it with caution. It is not just an antidote, it is a double-edged sword. It can provoke seizures and
yeah. Asavri, you have anything to say?
Yes, ma'am. Again, with the dosing only, use it with caution and with slow IV infusions or low initial doses. And you have to repeat it because of its short life,
Yeah.
if required. Yeah.
Forum, any take-home message?
Yeah, I think first is to increase the sensitivity and awareness about the incidence and occurrence of MH and the importance of dantrolene, because it was kind of unheard, but suddenly it has come into the picture because the cost is prohibitive. But it's a human life after all, so you have to procure it in some way, and we can't say at this age and day that we don't have when it is available, you know because yeah, so I think it has to be made available somewhere. At least you should have some dose to give with, because you should not be left with that I didn't have anything, though you're giving the supportive treatment. So
Manish, Nandini madam, one last question. Uh, there's one in the query box. Medico-legally, is it necessary to explain to the relatives that there is a possibility that MH can happen, and we couldn't, what if we couldn't get dantrolene, or any precautions or key points we should give for high risk patients of MH, for MH?
Yeah.
And how is it handled, the young losses, about explaining to the relatives? How is it to be handled in the growing, what you say, people, will just come and put do something to your nursing home. So in this
Yeah.
thing,
See,
how this needs to be handled?
absolutely. See, in this age when it is available, it is produced in the rest of the world, and but you don't have. I think that typically amounts to negligence, because definitely medical legal it has a great implications. If something is there but you are not keeping it only because of cost issue, then the whole responsibility comes to you and the institute where you are working, because it is their responsibility as well to keep all life-saving drugs. So now all these antidotes, and especially the expensive ones like Dantrolene, I think it is the combined responsibility of individuals, institutes, as well as the society, the specialty society, all that have a responsibility to make it available to use, because it is a question of one life. And if we are not going to procure it and give it to the patient, I think it definitely comes to the negligence, and I don't think you can stand in the court of law to defend yourself. So at least for that reason, whether it is you are going to save the life, giving it timely, untimely, whatever, or it is within reach or not. But if you used it, then you are safe that I have used everything possible, and may not be possible to save the life. So medical legally, I think it is very important. In fact, we were thinking of putting in a regular consent to put that malignant hypertension, but since we got the drug, then we dropped it. But of course, people are actually nowadays asking, is it a possibility that we read in paper, and is it going to happen to us also? So sometimes we have to counsel them that even if it is going to be there, we do have that antidote with us. So yeah, you're vulnerable for that medical legal aspect.
Thank you, madam. Aparna,
In
you
the
have something to take home for all of us?
Just if I may say something, in the list of essential drugs on your crash cart or in your OT, I don't think there is mention of dantrolene, which is why probably it is difficult to procure. But if there is some standardized thing, even I think intralipid as a part of essential is not mentioned. We have atropine, adrenaline, hydrocot, all the routine drugs that we use in our emergency drug chart. But these two drugs are not actually listed. So, if the new NMC or whoever brings the new regulations, if they can make it as a part of essential drugs on your chart, then maybe things would be simplified. And one more thing about one question which I think somebody has asked about, how do you explain to the relatives? Yes, it is very difficult to explain to the relatives in unexpected, unanticipated cases. But there are many conditions which we know are prone to malignant hyperthermia. In that cases, we should explain. For example, a few months back, I had a case of ectodermal hyperplasia. And this family was very much well aware of what can happen. They knew about malignant hyperthermia. Similarly, I think the DMDs or the muscular dystrophies who are, prone, if you can educate them, then they themselves will go and read up and they know. But we have to then look at alternative methods of using anesthesia, like we will avoid scoline, we avoid the inhalational agents and go for pure TIVA in susceptible cases. Otherwise, we are always caught unawares, no doubt about it.
Aparna, anything for us?
It was a wonderful presentation by all five of them. Really informative, very well done. So, and as I think that intralipid we have started, wherever we are giving blocks, intralipid is definitely checked and kept. And the way to convince the sisters to procure is that it is equivalent to adrenaline. Their common thing is, madam, 2 वर्षात expire होतं, मग आम्हाला ते फेकून द्या. I said nothing like that. Check every 6 months, close to expiry, send it to the ward to be used, and then you have to procure it. So I
Last
think
kit is always
dantrolene, sorry?
the last kit is always kept ready with intralipid in it. There's no
Yes,
alternative to that.
yes.
So,
Yeah.
shall we conclude, Manish?
Excuse me.
Yeah, somebody.
Excuse me, I am Dr. Reddy speaking from USA.
Hello, sir.
Yeah, I stopped working in anesthesia for a decade. Nearly in 2015, I stopped working. My last working station was SVS Medical College, Mehboob Nagar. And before that, I was in Kurnool Medical College, Kurnool. I retired as a professor in anesthesia, and I worked in Saudi Arabia for 9 years, way back from 1995 to 2004. And these topics, almost all these antidotes, very interesting topics you have selected. And moreover, I have seen dantrolene way back in 95 when I went to Saudi Arabia first. Unfortunately, I have not seen a case of malignant hyperthermia in my life. And I'm quite lucky that I have not seen. And flumazenil, I have never seen and I have never used. And the lipid, is only just they keep it as a fund in the whenever in regional anesthesia, but I haven't used. But naloxone, I had the opportunity to use several times because we were using way back in 91 when I came to Saudi first time. Fentanyl was available. It was not available in India at the time. So all this dandrolene also, I was not knowing that dandrolene is so expensive because it was freely available in Saudi Arabia. And in fact, I had the opportunity to work for a visitor come observer in New York and Tennessee for some time because my kids are here. And I have all these drugs, actually, there is no difficulty for procuring dandrolene or anything in these countries because they can afford for it. And even though we cannot afford, even though it's costing 100,000 rupees, I feel the life of a patient is more valuable than the money. So when you're practicing in THANE, you should have dandrolene sufficient, 120 milligrams doses, vials you can procure, you can pool at one place and utilize it, as they said. And regarding the use of Sugamidex, I put a question to Dr. Manisha that Sugamidex, how often they are using? Are we using? See, even now, I don't want to use Sugamidex. I still want to use neostigmine and glycopyrrolate only for reversal. Sugamidex is indicated only when there is difficulty in reversal, especially with rocuronium. The rocuronium, in fact, I had the opportunity to meet Dr. Mirakur from Ireland, who I met him in several conferences. In 1990 in Chennai, there is anesthesia ISA national conference. And
Dr. Appukutti had arranged it. Yes, sir. Yeah, that's it.
Yeah.
Yeah, go ahead, sir.
Hello?
Yeah, go ahead,
There's
sir.
some interruption.
Yeah, go ahead, sir.
Yeah. So that Mirakur has done a lot of work on this Sugamidex. But is it worth using Sugamidex in place of neostigmine and glycopyrrolate? I don't think. It should be reserved only for cases difficulty in reversal.
Exactly, sir. As I said, my first case was also in a case where it was a short procedure and scoline was contraindicated in that case. So I was left with rocuronium as a drug of choice for muscle relaxant. So then the choice was how do we reverse? Should we use Sugamadex to reverse the patient? Surprisingly, it was around the procedure lasted for around 30 minutes, 25 to 30 minutes. And since it was the first time we were using a reversal Sugamadex, we waited for another 5-10 minutes because I wanted that rocuronium metabolized. According to the recommended dose, it was 2 milligram per kg, but I chose to use 4 milligram. And extubation was absolutely smooth, sir. In fact, there was no tachycardia, there was no hypersecretions, what we generally face with neostigmine.
Yeah.
So it was quite a smooth extubation. And of course, inhalational and all were also titrated. The MAC was achieved for extubation. All the inhalationals were stopped on time. And I said, since it was the first time when we were using, we were more cautious. So yes, for routinely, it may not be recommended, but as in when we are using it for more common cases where rock is to be used instead of scoline, so succinylcholine, I think as in when we practice more and we do more number of cases, the confidence rises, and that's when we choose
But the cost
Sugamadex.
is high, as you said.
Yes,
It's
cost.
about.
So if you see the cost right now available, the brand available is 800 rupees a vial. So we don't need more than 2 vials. So and you can
So it's
actually
around 16.
adjust.
No. I mean, it's around 1,600 rupees to reverse a patient.
Yes.
It's very expensive when we can get away with neostigmine and glycopyrrolate.
I think that's a difference. I think we as a younger generation, we feel that cost may not always be an issue. Working in a corporate hospitals, we always feel that can be tackled by
No, I mean
the.
those days when I was practicing way back in 1980s, from 80s to 2015, it was cost. I mean, it is prohibitive.
Yes.
It was expensive actually.
So when the
Though it was
management
introduced.
actually gives, so when the management actually gives us a free hand for open consumables,
You're very
I
happy.
think we.
Yeah,
No,
yeah.
no, 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 no,
When the
no.
management is, I mean, giving through hand, there is no problem in using it. But the for patient could afford it for it, you know.
So,
Yeah,
so
true.
with the
No,
rising number of insurance patients coming to us, I don't think cost is really a matter
no,
nowadays.
no, 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 no.
But
I think, sir,
I, I may
Sankade
there
sir
may be
has
a
been on both
difference.
sides,
no, no. So
but
I would,
I tell
sir,
you,
giving funds as well as, working as anesthetist. So,
so Dr. Reddy, can I talk, Dr.
yeah.
Sana? Yeah.
yeah.
See, regarding, I've since 2006, I've been visiting a hospital. One case long back in 77, a patient who had a abscess and was taken for a surgery. Anesthetists used suxamethonium and ether. In 76, ether was very popular in a rural
Yeah.
area, and that's a typical combination. When he tried to intubate the patient, he found a great
Yeah.
rigidity. So, moment you give
Okay.
suxamethonium or anesthetist gives a suxamethonium, he finds a great rigidity, tachycardia, and hyperpyrexia. That is the first indication something is wrong with the patient. This, but now with the new muscle
Yeah.
relaxer and no halothane, and then Dr. Manisha said is if you can ventilate patient well, then if you can avoid suxamethonium, nothing like it. Because today I had a cardiac patient, thin lean easy intubation. So I prefer to use rock. But now what I see with the common anesthetist here, they use suxamethonium for intubation. For maintenance, they use rock. And for reversal, they use suxamethonium, sugammadex. So,
Where?
yeah, in India, I've seen now younger
Okay.
generation, like I've seen younger,
Yeah, they don't bother about the money.
yeah, no, they don't bother about the money. But when it comes to, see, rock, if you use 3 vials of rock and you use a sugammadex, the total cost goes up almost 4 times, almost like it goes to about 3,000 rupees for muscle relax and sugammadex.
And even rocuronium is expensive.
Yes. Now comes to cis atracurium and atracurium. They have got a great tendency for Hofmann elimination because
Yeah.
and now rocuronium doesn't have much established Hofmann elimination. Now regarding
Yeah.
neostigmine, how neostigmine reverses atracurium, cis atracurium, or even for that matter, no vecuronium, is by
Yeah.
acetylcholine liberation at the synaptic level.
Yes.
And sugammadex, if it has to work at the level of rocuronium or vecuronium, it covers the molecule and obstructs the molecule. So what they
Yes.
say, the reversal of sugammadex is faster with rock as compared to neostigmine. Neostigmine may take some longer time, but if you are with the new muscle relaxer, with new inhalation anesthetics like sevoflurane or even other things like Baxter's, so this new muscle desflurane, the patient they get reversed very fast. So their awareness
Yeah.
level goes very high. So it is an individual anesthetist what he has to know. People like Manisha may not bother, but sometimes in a nursing home, the surgeon gives a quotation to the patient that, your surgery will be done at this cost. So surgery, anesthesia, OT, and he gives a quotation, rough quotation, your total bill will be X amount. And when it goes to X plus 10%, the relatives go and fight with the surgeons. Dr. Manisha, are you with me? So, yeah, that is
So one thing is
yeah.
definitely I would like
Not
to
only
say,
that.
according to the studies, also there is no added advantage of using sugammadex over neostigmine, except that the faster recovery. But of course, the choice of patient in which we are using rock and then sugammadex is what matters. So on a routine basis, it has no added advantage. Many studies have recommended that.
Sir,
Yeah,
since you may I say something? Since you were talking about the financial aspects of it, there are two solutions which have come up. One is that
Yeah.
you use Sugamadex with vecuronium. That works out
Mhm.
cheaper rather than using rocuronium. And second option is given to us by the pharma company themselves. They say you use Sugamadex, we will give rocuronium free.
No, I'll tell you a
And
thing. Still one more solution, Dr. Manisha,
yes,
is
sir.
we are going by MRP. If
Yeah.
you study the cost of the drugs to the hospital, see the profit margin for the chemist is huge. Sometimes the chemists are making more money than anesthesiologists.
Always, sir.
Actually, the pricing.
So pricing is, so if you can work out, you want the best and you want at a reasonable cost, then hospitals, certain anesthetic drugs, if they can procure at the retailer or the dealer's price, it will really work very well. So now the anesthetist, as far as anesthesia is concerned, the time has come medico legally. We should not make any compromise also because people are well read and they are aware what is happening. And with the chat GPT tells you what they can do. Chat GPT, you put, they will give the what anesthesia procedure you can follow and what are the drugs to be used also.
So
So,
one more thing I wanted to point out is when we use a particular drug on a routine basis, and then when we want to use it on an emergency, like a CVCI situation, we are a little more confident about using it.
yes,
So
yes,
it's
I
like
agree with
training
you.
our mind to use it in a routine.
Yeah, and
Yes.
if patients are coming with risk factors, multiple risk factors, or it is a long-standing surgery, if they can pay for a robotic case, they can pay for Sugammadex. Better get used to it because there will be many other drugs which are shorter acting and get out of the system very fast. And one such drug in this thing, as Manisha madam pointed out, was Calabdion, another
Yeah.
new reversal around the block. Okay, so our learning never stops here. Things will be improving for the betterment, and the newer generation don't have to resort back to ether, but you'll have to move forward with the agents which are best available at hand to use and be comfortable using them. So with this, I think I should conclude this CME.
Just I want to say one thing to Dr. Sunil.
Yes, sir.
Yes, sir. Yes, sir. Go ahead, sir. It's
Yeah.
nice.
Dr. Sunil, have you seen anybody using succinylcholine for intubation in United States?
No, they keep it handy loaded next to anesthesia machine for a crash
Yeah.
intubation. Suppose if they find this patient is for emergency intubation, number one.
Yeah.
Number two is they find this patient may be difficult to intubate whether. So, but they keep it loaded next to anesthesia trolley in emergency with the
And routinely, what I have
wrong.
noticed here, they are using only non-depolarizing muscle
Yeah,
accent for intubation.
they are
And
using only
most of the time, either vecuronium or atracurium.
Yes.
And I have not seen cisatracurium. It's available in India?
Oh yeah, it's plenty. I've been using plenty. In fact, cisatracurium,
I haven't seen, because I stopped working. I haven't seen cisatracurium. I have used atracurium and this vecuronium only, and rocuronium very rarely used because only for patients where I wanted to avoid succinylcholine, I used rocuronium in India.
Thank you, sir. Sir, you have taken me to my old memories in 1990 because Professor Mirakud used to come very often to India. And in 1990, Professor
Yeah, he
Apo,
was coming from Ireland, like he was, and he has done a lot of work on Sugammadex.
And then, he used to come, Dr. Professor Apu Kuti had arranged a conference in 1990.
Yes, Apukuti is no more. He is no more. Apukuti, pediatric anesthesiologist from Egmore Children's Hospital.
Oh yeah, he was a fantastic and a very good organizer. And I remember the banquet in Taj. That's nice. And regarding this,
now also now there is one more institution, some child center, what is it? Hospital is there? Child Trust Hospital, something. There is one anesthetist. He's also very popular. I forgot his name.
Then about this, there is one person named Dr. Patel, who is in University of Southern California. He's a medical director. He has done lots of work on Sugammadex. In fact, he is a teaching director. He's from actually I had an interaction with him. In fact, last ASA, he had arranged a meeting. So these new drugs are really picking up very well, sir. Rock and sugar
Yeah.
eggs. And I'm glad this intralipid concept and people.
So,
Yeah, thank you.
yeah, excuse, where are you actually? Where are you working?
Oh, I'm working in Thana. I'm working in Thana. I go as a visitor.
Okay.
So yeah, so because I work in Thana, but I get opportunity to visit since. And
Yeah.
so whenever I go, my children are in San Jose.
And
So,
this time, where is the national conference in November? Where it is?
yeah, Raipur. It is in November.
Raipur.
Yes, sir.
Okay. Okay.
So where you? Okay.
Pardon?
So which year you passed, sir?
I am graduated in 1969.
Wow, 69. MD
I
anesthesia.
finished my housemanship in 70, and
Okay.
but I did my anesthesia very late from 84.
Where, sir? From where, bro?
From Kurnool Medical College, Andhra Pradesh.
Okay. Wow, very good. Okay, chalo. I think Sonali wants to wind up the meeting. We can talk.
Yeah, thank you very much. Thank you.
Thank you.
Thank you.
Thanks, sir.
I got this link from SVS Medical College because I worked for 8 years there.
World is small.
It is in Mehboob Nagar, near Hyderabad.
Webinar, sir. Anybody can join from anywhere in the world.
Yeah.
So regarding, I want to know about intubation. You have traveled all over the world. Now, I think, every anesthesiologist, they have a skill of intubating their regional patients. What I guess, this is unofficial, I heard a very vague comment. For example, if I get an Arab patient to intubate, I may be scared to intubate I will think twice and look at the obesity and thick jaw. Then if you get Filipino, then they may difficulty. And some people they have difficulty in anesthetizing Indian patients who have got a contractures or the submucous fibrosis. What is your experience on this?
My experience in Saudi Arabia, actually, the patients are very they are obese and they are muscular and nearly. I anesthetized a patient for about 250 kilos.
Okay, so what muscle relaxant?
It was a case for cesarean section.
So okay, you just spine. Okay.
And the patient, the gravida was 17th gravida.
How much?
17th gravida.
Oh.
I have seen even 22 gravida also. And I worked in a high-risk anesthesia obstetric hospital in Aba, in Asir province.
So what are your protocols for intubating these patients?
We didn't have anything. We didn't except stillate or anything. And extra large blade we had. And that time video laryngoscope was not available. It was in 2000. So we have to use our own skills.
Oh. Okay.
We used to get this pregnancy-induced hypertension cases, preeclampsia, eclampsia cases, at least 2 or 3 cases in a week. And I mean, all high-risk cases, they used to refer to us.
Oh, very nice.
Placenta incretas, we have seen plenty. And we would have transfused at least 10 units. Packet cells, then platelets. It was all, but we never had a single case. We never lost single case.
Interesting.
It was very interesting. Actually, I thought if such cases, if I had to anesthetize in India, the mortality would have been very high.
Excuse me, Dr. Sonali and Manisha for taking.
Yeah.
So
very interesting.
Yeah.
Thank you, sir. Thank you for your input.
It was very
thank you.
interesting.
Thank you, everybody. Thank you, everybody.
Yeah.
Thank you.
Yeah. So to conclude, we just chose the 5 antidotes regarding the group of drugs that we are routinely using in anesthesia on a day-to-day basis. There are many more antidotes. You can find a list from A to Z. For every drug, there is an antidote, and it will, it just requires a little knowledge, a little patience, and a good critical care consultant behind you where to recover these patients, because most of these drugs may have a biphasic response, as it was pointed out, or may require infusions to be going on for a longer time. So with this take-home messages, I thank all our participants who have been with us to the end of the session. I thank the inputs of Dr. Nandini and Dr. Aparna Nerurkar. Thank you for joining us and guiding us. I thank all our speakers, Dr. Manisha, Dr. Aditi, Dr. Asavri, Dr. Divya, and Dr. Forum for this insightful and practical points which you have given us. Thank you, Manisha Ghosh Madam and Nilima Madam for giving us this opportunity to present it on this scale. And it was quite interesting to hear the discussions and the takes on these new drugs. So thank you so much. And Manisha, we conclude the meeting.
Yeah, Nilima will say a few words.
Yes, yes. No, it was a really very engaging webinar, and I would like to thank THANE ISA office bearers, Dr. Sunil Katkade sir, Dr. Manisha Ghosh, and Dr. Parna Thakkar, Secretary THANE ISA. Thank you, SAM's office bearers. Then I think we have forgotten to thank Ganesh. Ganesh from Geneta. He is a very important person.
Yeah.
Very helpful and very important person. And last but not the least, thank you so much, Dr. Sonali Saraf. She beautifully moderated the entire session and made it very interesting with a lot of difficult case scenarios.
Thank you so much.
Thank you.
Thank you, Dr. Sonali.
Overwhelming response.
Thank you.
So when we decided this webinar, I told Sonali and Nilima only one thing. I don't want a lecture in pharmacology. It has to be very clinical and practical with take-home messages. And I think they've done a superb job. Thank you, Nilima. Thank you, Sonali. And thanks to all my lovely speakers.
Thank you, speakers.
Thank you so
Thank you
much,
very
ma'am.
much.
Thank you.
Thank you, Doctor.
Indeed
Thank
a
you, Doctor.
pleasure.
Thank you.
Dr. Manisha, can I talk now if the official
Yes,
meeting is
sure,
over?
sure. Go ahead, go ahead.
Very important carry home message Dr. Reddy has given is to have a helpline number. So if every OT we can display some helpline number, for example, they can always talk to some seniors or people who are more experienced. In fact, what happens with anesthetists, particularly nursing home anesthesiologist, he's a solo pilot and he requires some guidance in certain situations. Every time he not access to a latest clinical literature. So what Dr. Reddy has suggested, in Thane at least we can start putting some helpline numbers in case of suppose if patient has you have some difficulty, or you can make a group where you can helpline numbers and people can talk
So
in
that others
confidence.
also can become alert and immediately act.
Yes,
And
that's
save
a
the
very,
patient life.
yeah, that's a very important
The
thing which you
training of
suggested.
OT staff should happen on a regular basis, like mock drills and educating them. That should
Yes,
happen
yes.
on a regular basis. Because sir, when you are in need and you call up, now the others might be busy and there might be nobody to come down. And the person who is in trouble has no time to make phone calls. So that one designated person who will call and somebody will come, that is very important.
Sir,
But let us start. We can try put some
Yeah, we
helpline
can try
numbers.
that. So
some
what
group.
we can actually do is our RMOs and our OT sisters who inform us about the case for the next day. What I do in practice is I tell them to send me a photo of the picture, a photograph of the patient. So when I look at the photograph only, I know, chalo, can I sleep peacefully tonight or do I have to call somebody else with me in the morning? So that is one thing they have got so used to it now. So they are only telling me, madam, this weight is 90 kilos, huh? So like or 100. So like I know, then immediately the picture will come. So we have to train the people who are around us first, and then hopefully such a situation will not arise only because we know it is difficult. So we keep our equipment ready and we also call, sir, Katkade sir, are you free? Can you come for conduction, that kind of thing.
Yeah, that's
So
correct. Yes,
at,
that's
at
Why
right.
we had that
money is
overwhelming
not so
response.
important. The safety is more important. Manisha, sorry, you were saying something.
The response we had for that technician training. In fact, even now I'm getting
Yes.
queries whether we are having one more
I
session
think
for it.
I hope so. I hope so. We should do one more.
Yeah, we must.
Yeah.
Thank you very much. Thank you very much.
Thank you very
Thank
much.
you.
Thanks
Thank
a
you,
lot.
doctor. Thank you.
And
Thank you, sir.
Dr. Reddy sir,
Yeah.
can I have your number? Can I have your number,
Yeah.
please, if possible?
Yeah.
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 I can. Yeah, you can switch off. Yeah, please. Okay.
Thank you.
My number is
No, yeah.
9347
Okay. 1 minute.
701.
Yeah, you can. Manisha, you.
Sir, wait 1 minute. Sir, give me a pen, please.
Open.
Wait, I will write it down.
Type on the group.
No,
Chat,
type on
put it
again.
in the chat box.
No, right on 937.
No, my number is not 937.
Oh,
Sir,
yeah.
number, I will write it down.
347
347 area code. Yes.
701
701
1258.
1258. Okay.
This is my WhatsApp number.
Yeah, 347 701 1258. Okay.
Yeah, your number.
Yeah, you can take 091 is the area code, country code.
1 second. Let me have a pen.
Yeah.
Sir, you have got Reddy sir's number, Dr. Rupa's number. You've got Katkade sir.
So, 1 minute. Just 1 minute.
Dr.
Just.
Vijay sir.
Yeah.
See, you tell me the number, I will write it down.
No, I'll add it to our Anaesthesia group. 347 701 1258. Am I right?
Yeah. 347 701 1258. Yes.
Yeah. And my number is 091 is the area country code, India.
Okay.
And mobile and WhatsApp number is 98.
Okay.
20
980
98200
2
double zero
982
200.
Oh, 9800.
No, 98200.
Okay.
59431.
59431. 431. And Dr. Sunil.
Yes, sir.
Okay. So you are in THANE.
Yeah, I'm born and brought up in THANE, sir.
Okay.
I gave my first anesthesia in 75 for a rupture uterus under local anesthesia. And that was the
Okay,
intern,
okay.
and then chala. Okay, sir. Pleasure talking to you. Thank you very much.
And very, I mean, we can talk in WhatsApp. Actually, there are many things actually.
Yes. See, for example, lots of things we did under open ether.
And I was also under the same impression when I went to Saudi Arabia first time. I thought we will have a lot of difficult intubations. And very rarely I had difficult intubations in Saudi Arabia in 9 years. I encountered more difficult intubations in India rather than Saudi Arabia.
Yes, even I met some anesthesiologists who are practicing in USA. They are more careful when Indian patient comes to them. And other people, they are slightly careful are our Filipinos. My colleague.
And those days, I was in Saudi till 2004. Afterwards, I came back to India and worked in SPS Medical College, Melbourne.
Sir, please may I request you to continue this in private because I have to end the meeting.
Yeah. Thank you, madam.
You can leave the meeting. Bye. Yeah. Thank you.
Yeah, we have got the numbers. No problem.
I think, Manisha,
I am the host, so if I end the meeting, probably everybody might get disconnected. That's
Okay, we shall meet in national
We
conference.
will add you to our WhatsApp group, sir. We can continue the chat there. Thank you,
madam. Thank you.
And if you have any photographs, kindly put them. Okay. Thank you. Okay.
Thank you.
Thank you. Good night.
Thank you, Dr. Manisha. Thanks.
Good night for you.
Thank you.
Yes, it's good morning for you.